Future Pulse, investigating innovative cardiovascular research and the intersection of academic theory and clinical practice. I'm Dr. Thomas Nero, interventional cardiologist and director of cardiovascular research at CAFC. Good morning and welcome to Future Pulse. I'm Dr. Tom Nero. Today we have the pleasure of speaking with Dr. Stefan Neubauer regarding coronary inflammation and cardiovascular risk assessment. Dr. Neubauer is the head of the Division of Cardiovascular Medicine at the University of Oxford and is also the lead of the imaging team for the Oxford Biomedical Research Center, which he's headed since 2017. Finally, he is one of the co-founders of Cristo Diagnostics, which is a leader in advanced CT imaging. This is going to be the first of 4 podcasts that we're going to be doing on inflammation, and probably one of the most important, as we're going to be going over some of the new trials and papers that Dr. Neubauer has published with the use of fat attenuation indexing and cardiovascular inflammation. Enjoy. Thank you for joining us.
Good afternoon. My pleasure to be with you today.
So I was very excited to read your papers that you've just published on coronary inflammation and the risk identification that's associated with it. I've been a fan of your research for many years, and I initially was working in cardiac MR 25 years ago. So I've been well aware of your research. But what's interesting to me is that you moved from doing research in cardiac MR into doing cardiac CT. What prompted that change?
Yeah, okay. So for a long time, I felt that cardiac CT research was mostly focused on a single question, and that is, what is the sensitivity and specificity for detecting significant coronary stenosis? And to be honest, I found that a bit limiting. However, over the past 10 to 15 years, that situation has completely changed. And the recent progress in cardiac CT has been truly breathtaking, I would say. What's fortunate from my point of view is that at this point, cardiac MR and cardiac CT are still really quite complementary. For example, cardiac CT is no doubt better for assessing all aspects of the coronaries, while cardiac MR is clearly superior for myocardial tissue characterization, such as in cardiomyopathies, for example. So I really saw it as a game changer that CT can now give us precise non-invasive information on coronary lumen, extent and quality of coronary plaque, and as we'll talk about in a moment, information on inflammation based on pericoronary fat analysis. And all that really stoked my interest in cardiac CT, and that just wasn't there in the early days of cardiac CT. So how did I get involved in all this then? So maybe firstly, I can briefly summarize, as of course you're aware, inflammation is the main driver for coronary atherosclerosis, and not only for the development of coronary plaque, but also for the vulnerability of these plaques to rupture and trigger an MI. And we've also seen in recent clinical trials that specifically targeting inflammation can reduce cardiovascular events. So I'm referring to CANTOS, cohort, LODOCO2, etc. And until now, a test that can non-invasively detect and quantify this inflammation simply did not exist. And so it seemed likely to us that such a test would allow us to better risk stratify patients than what is possible with conventional methods, such as by using the traditional risk factors. So then if we go back in time, many years ago, I watched how Haris Antoniades, a colleague and close collaborator of mine in Oxford, and he's also the deputy head of my division, how he made a fundamental discovery in his basic science lab. And so using transcriptomic analysis of human tissue samples from patients undergoing cardiac surgery, he found that inflamed coronary artery walls send inflammatory mediator molecules into the surrounding fat tissue. What happens next is these fat cells then start to shrink, lose much of their fat content as a reaction to the inflammation signals, and more precisely due to inhibition of adipogenesis, increased lipolysis, and edema formation. The result of this is that overall the fat tissue becomes more watery in composition, and the closer the adipose tissue gets to the inflamed artery wall, the stronger this effect is. Water, as you know, has greater radial density than fat tissue, and therefore we felt we can use cardiac CT to image the changes in CT signal in the pericoronary fat. And if you want, these changes can act like a thermometer of inflammation. And so the measurement we then developed to quantify this is called the Coronary Fat Attenuation Index, or FAI. And we published these findings in a landmark paper in Science Translational Medicine in 2017. What is astonishing is that these FAI signals have always been there. ever since we've started to do coronary CT. But no one knew that they existed, and no one knew how to extract them. And so this means that not only can we do this analysis prospectively in patients who have coronary CT scans now, but we can also go back to old scans and do the analysis retrospectively without the patient needing to repeat the CT. And so the next step for us was to then assess whether this FAI index is actually clinically useful or whether it's just some crazy theoretical idea, whether it's a strong predictor of cardiac mortality. So then in a paper published in the Lancet in 2018, a year after the seminal Science Translational Medicine paper, we looked at two different groups of about 2,000 patients each, one from Erlangen in Germany with Stefan Achenbach, the other from Cleveland Clinic with Milind Desai. All patients presented with chest pain and had an initial diagnostic coronary CT scan. And indeed, we found that the FAI index was a strong predictor of cardiac death. And in these two cohorts, patients with an abnormal FAI index were 9 times and 6 times more likely to suffer a cardiac death over the next 8 years. So importantly, this prognostic information was independent from the traditional cardiovascular risk factors. So then this result convinced us that here looks like we have a technique that will allow us to greatly improve risk prediction in cardiovascular disease. However, at the same time, we realized that these raw measurements of FAI are influenced by many other factors and need to be standardized to actually provide robust clinical information. And this suggested to us that there is a great opportunity to make this happen and to develop a regulated and reliable clinical product with a spin-out company. And this is, as the final piece of the puzzle, if you want, led us to found Caristo Diagnostic, where Caristo stands for Cardiac Risk Stop. So that's kind of, in a nutshell, the history of this.
So the CRISP-CT study is extremely interesting for multiple reasons. The one that you were describing being the most important is that it's so prognostically granular, right? It can really demonstrate people who have extremely high risk versus people who have very low risk.
Yes.
The other thing that came out of CRISP-CT that I was always interested in was that patients who were on therapy and who were on statin therapy, on aspirin, also had decreased FAI, that it was parallel to their decrease in risk, which is quite interesting that you could see the attenuation with therapy.
Yeah.
And that's actually one of the more interesting areas that we're going to touch on a little bit today in the second paper, not just a way of identifying risk, but adjudicating risk and adjudicating the effectiveness of therapy.
Absolutely.
So the ORFAN trial, which is what we're going to be discussing, was initially presented at the AHA. Mm-hmm. They gave the top line results, and now you've published the full paper, which is just incredible in its detail. And I would recommend everyone take a look at it in the Lancet because it's breathtaking.
Yes. So we published very recently this landmark paper in the Lancet. And the exact title is Inflammatory Risk and Cardiovascular Events in Patients Without Obstructive Coronary Disease, the ORFAN multicentre longitudinal cohort study. And probably the starting point should be to explain what the ORFAN study actually is. And this paper is really only one aspect, or if you want, the beginning of mining this huge database of ORFAN. So it's the largest cardiac CT registry worldwide. It aims to collect cardiac CT scans linked with 15-year clinical outcome data from eventually 250,000 patients, but we have already collected data from about 130,000 of them. About 80% of these patients are from the UK, where we link with NHS Digital and other national electronic health record databases. About 20% are from various other countries, including the US. And looking at the first 84,000 patients from this registry, we already have over 3,600 MIs, 2,900 cardiac deaths. So we are strongly powered for outcome prediction, even now. So the current study comes in 3 parts. And as you say, it's quite a large and complex piece of work. So let me explain the main points in some detail. In the first part, we looked at about 40,000 patients from 8 UK hospitals who underwent clinically indicated CCTA, in other words, done to investigate chest pain. And we found that about 20% of these patients had obstructive coronary disease requiring further investigation or often intervention. About 80% did not have obstructive coronary disease. Now, after multiple adjustments for risk factors and other factors, we found that patients with obstructive coronary disease were significantly more likely to suffer a clinical event, so MACE or cardiac death, compared to patients with no obstructive coronary disease. This is, of course, entirely expected. However, in the group with no obstructive coronary disease, which was 4 times larger in our study, in absolute terms, both the numbers of cardiac deaths and MACE were about twice as high compared to the group with obstructive coronary disease. So to give you a concrete example, 1,118 cardiac deaths in the non-obstructive group compared to 636 cardiac deaths in the obstructive group. So I think this is a striking finding, and it highlights the unmet need to improve risk stratification and management in the population without obstructive coronary disease on CCTA. So that's the first part. In the second part, we then looked at the prognostic value of FAI score in the presence and absence of obstructive coronary disease. This is new compared to the previous Lancet paper. We did this in about 3,400 patients from the 2 hospitals in the ORFAN registry with the longest patient follow-up data. And in this population, we then evaluated an artificial intelligence enhanced cardiac risk prediction algorithm. That's quite a mouthful. And that's called AI risk in the paper. And it's called Cari-Heart risk in the clinical product from our spin-out company, Caristo. And as I explained, this is an algorithm that integrates FAI score, coronary plaque metrics, and clinical risk factors all together. So here, firstly, we showed that FAI score predicted cardiac mortality and MACE in both patients with and without obstructive coronary disease. And this effect was consistent for all 3 main coronary arteries, the LAD, circumflex, and RCA. In the original paper, the circumflex didn't quite reach significance. We say in the paper that this finding reflects the total inflammatory cardiovascular risk. And to just give you one numeric example for cardiac mortality, when comparing the lowest and highest quartile for FAI score in the LAD, the highest quartile had a hazard ratio of 20. So cardiac mortality in these patients was 20 times higher than in patients in the lowest FAI quartile. And then similar results were seen for all 3 coronary arteries. And for MACE events, hazard ratio for the LAD was 7. So that's the total inflammatory risk. Now, we know that clinical cardiovascular risk factors contribute to atherosclerosis, at least in part, also by increasing vascular inflammation. And so the next step was we also assessed the remaining residual inflammatory cardiovascular risk sort of on top of the clinical risk factors. And so we did this, as you would assume, by adjusting the hazard ratios for cardiovascular risk factors, hypertension, diabetes, hyperlipidemia, smoking, but also for the extent of coronary atherosclerosis, which we quantified with the CADRATS-2 score. Here we showed that the FAI score captures the residual inflammatory risk even after adjusting for risk factors and the extent of any obstructive or non-obstructive atheroma. So again, to give you the same example for the LAD with regard to cardiac mortality, comparing FAI score quartiles 1 and 4, after adjusting for all these factors, we still get a hazard ratio of 8, not quite 20, but still 8, still very high. And that is the residual inflammatory risk. And let me add here that the total inflammatory risk is what is ultimately clinically relevant and the patient needs to know about. But the residual inflammatory risk is also interesting. It's scientifically interesting, but also because that is the component you can specifically target with anti-inflammatory treatment. There were several further subgroup analyses that are worth mentioning. So firstly, these effects I've just described were maintained when we excluded patients with prior MI and prior revascularization. Secondly, we looked at the 1,300 patients where we also had non-contrast CT scans for calcium scoring. When we adjusted for that, the results held up. Thirdly, FAI score was also predictive in patients with chronic inflammatory diseases like rheumatoid arthritis, etc. And then finally, and this in my mind is the most striking finding of the entire study, in about 1,700 patients with no or minimal atheroma on CCTA, that's CADRATS 0 or 1, the FAI score in any coronary artery was still highly predictive of cardiac mortality, with a hazard ratio of 10, comparing the first and fourth quartile for the LAD. And it also remained highly predictive for MACE with a hazard ratio of 6. And remember, these are the patients who typically completely reassured that they apparently have a normal CT scan.
What was impressive to me about that was that 10 times risk factor was consistent regardless of cholesterol, regardless of smoking. This is just about inflammation.
Exactly. The next thing we did that I think was interesting was we examined whether it matters how many coronary arteries are inflamed, and specifically how many have a high FAI score in the fourth quartile. Although we found the presence of one inflamed artery was enough to provide strong prognostic value, we also found that the more arteries there were with a high FAI score, the higher was the risk for both cardiac mortality and MACE when compared to patients with all three arteries in the lowest FAI score quartile. And this again was the case for patients with and without obstructive coronary disease. So when you compare patients with no vessels at all inflamed with patients where all three vessels are inflamed in the fourth quartile, the hazard ratio for that latter group is 30 for cardiac mortality and 13 for MACE. So there is also a dose effect if you want. I think these are astonishing numbers.
They really are. When we talk about increased risk with inflammation and hsCRP, in the highest risk HRP study that they've done, it increased the risk by 0.72 or 72%, which is pretty high over a 5-year period, where what you're showing is a 2,900% risk increase.
Yeah.
I mean, it is astounding.
But it is 10 years. So the next thing is if we move on from FAI score, we evaluated the performance of this AI risk classification, or as Caristo calls it, the performance of Carry-Hard risk. And this Carry-Hard device typically gives the 8-year risk in percent of the individual patient for a fatal cardiac event. That's what we've developed so far. But with these new data, we can now extend this to assessing the 10-year risk because we have more late endpoints. And so this Carry-Hard risk device classifies patients into 3 categories. Category 1 is low to moderate risk. This is less than 5% 10-year risk. Category 2 is high risk. This is 5 to 10% risk. Category 3 is very high risk, more than 10%. And so using this Carry-Hard risk classification system, we found that patients in the very high risk category had a significantly higher chance for both cardiac mortality and MACE compared to those in the low to moderate risk category. Hazard ratio here was 7. And again, this was seen for both patients with and without obstructive coronary disease. Then just maybe 2 other things we did, and then I think I'm done describing this quite complex study. So the next thing we did was we compared the Carry-Hard risk classification with the risk classification we typically do in the UK with the QRISK-3 algorithm. We use the score here in clinical practice quite regularly. And the Carry-Hard risk algorithm led to reclassification to higher risk in about 30% of patients and to lower risk in about 10% of patients. So overall, about 40% of the patients were reclassified in terms of their cardiovascular risk. And these results were again similar for patients with and without obstructive coronary disease. So then the last thing we did was we evaluated the impact of the FAI score and Carry-Hard results on clinical decision-making in a real-world survey in 744 patients who underwent CCTA for investigation of chest pain, and making this information available to the clinical care teams in 4 UK hospitals led to a management change in 45% of the patients. These changes typically included initiation of statin treatment that hadn't previously been planned, an increase in the statin dose, or adding additional treatments beyond statins. So that's this mega opus.
The takeaways for the paper, which I think are really wonderful, and obviously this is a real tour de force in the importance of the utilization of FAI in determining cardiovascular risk. It reiterated the importance of what we've already known, that it's not necessarily stenosis or obstructive disease, that the risk assessment, when you eliminate obstruction, when you eliminate plaque burden, is still there. And it is as important for patients who have mild plaque, moderate plaque, severe plaque. And that really matches what we've been talking to about patients and their coronary disease for years, that it's not the narrowing, that it's really about the metabolic activity of the plaque.
That's exactly our point.
And I think that's really probably the most important point here.
Yes.
The other interesting thing is that the high rates of events that you saw in the obstructive disease group was biased because you gave them information that had obstruction on the CCTA.
Yeah.
And so that drove a lot of the interventions early in the obstructive group.
Mm-hmm.
And I sort of wonder if you had taken that piece out, whether or not you would have seen the difference that you did, because there was a difference in obstruction versus non-obstructive in patients who were intervened on, but it was somewhat biased.
Yeah. That might well be the case. This is a pragmatic study. It's using existing data, so we don't have to wait for 10 years until we get a result. And of course, these are patients who were referred for the assessment of chest pain and had a CT coronary angiogram for that reason. And it is possible that if you took a completely unselected group of patients, that the result might be slightly different, somewhat different. But I would say the strength of the signal cannot be argued with.
The other thing that I found that's really interesting is that when you had such a large sample size, that when you looked at those patients, they also included patients with rheumatologic diseases and other underlying diseases. And previously, we really didn't have quite as good data on that group. And that regardless of the cause of inflammation in the coronary arteries did seem to have the effect of having increased events.
Yeah. So that's right. We are still in the process of doing separate full-scale analyses of these subgroups of patients. So the good thing about ORFAN is that, eventually we will have a couple of thousand patients with rheumatoid arthritis, with psoriasis, etc. And we will do separate analyses, just like we will do them for other subgroups in, ethnic background and all kinds of factors. So I think that is still for the future to be worked out precisely, but that's the opportunity that's still to come.
One of the questions I had while discussing this with some folks at the Cleveland Clinic was that they were interested in the fact that not everyone who has elevated hsCRP has an elevated FAI score, and that not everyone who has an elevated FAI score has an elevated hsCRP.
Yeah.
Can you just discuss the difference between the coronary inflammation that you're seeing and systemic inflammation?
When you look at the correlation in this large database between these two parameters, it is highly significant, but it's not very strong. It's between 0.1 and 0.2 is the correlation coefficient. And of course, these are two different things. The CRP measuring the systemic inflammation, but you don't know where exactly it's coming from. There may be some component from the coronaries, but the inflammation can be anywhere in the body, while this imaging-derived measure is very specific for the coronaries. But of course, in the fullness of time, we're going to have to analyze how the CRP measurements directly compare in terms of prediction with the FAI measurements. That means we have to do prospective studies because we don't have CRP measurements in ORFAN at the time of the CT study. We have blood tests, but they might have been taken years before the CT. That direct comparison of their predictive power in a proper fully powered research study. We also have a prospective arm in ORFAN where we are recruiting patients prospectively, and we already have several thousand in that arm. But again, that is information that is going to come in coming years or maybe even months.
Well, let's go on to the second paper that was recently presented at the ACC, and also it was also published for an antioxidized LDL. Can you go into that study and how it demonstrates the benefits of FAI?
Both academically and with Caristo, we're doing a lot of studies with pharma where we look at the ability of FAI score to monitor anti-inflammatory effects. And also we're looking at how the FAI score technology can select the right patients for the right clinical trials. So there is this very recent study where Caristo is a collaborator, published in Cardiovascular Research with Chris Farina as the first author. The exact title is Inhibition of Oxidized Low-Density Lipoprotein with Orticumab Inhibits Coronary Inflammation and Reduces Residual Inflammatory Risk in Psoriasis, a pilot randomized double-blind placebo-controlled trial. So we did this together with the pharma company Abcentra from California, and they have a drug called Orticumab. This is a human monoclonal antibody against a specific OXLDL epitope, and this is thought to suppress coronary inflammation by inhibiting OXLDL-induced macrophage activation in atherosclerotic plaques. And there's preclinical evidence of that mechanism. This was a randomized, double-blind, multicenter, and placebo-controlled trial in psoriasis. And these patients are known to be at increased cardiovascular risk. And the study assessed the effects of this drug on coronary inflammation as we measured it with FAI Score and carry heart risk. So CCTA was performed at baseline and at 15 weeks in 32 patients in the orticumab group, in 19 patients in the placebo group. Patients were divided into those with low and high coronary inflammation at baseline according to their initial FAI score. And this allowed analysis of the importance of baseline coronary inflammation here. Now, for the whole population, there was a trend towards reduced coronary inflammation in response to this drug in all three coronary arteries, but it clearly wasn't significant. But in the subgroup with elevated coronary inflammation at baseline, orticumab significantly reduced FAI score in the RCA, in the circumflex, and showed a strong trend in the LAD with a P of 0.06. Now, in contrast, in the low inflammation groups, there were no significant changes in FAI score in any of the arteries. And then in addition to that, with orticumab, the carry heart risk dropped by about 50% in the high inflammation subgroup. And this study suggests that the combination of FAI score, screening, and orticumab treatment could be used to identify and reduce coronary risk in this population and select those patients for treatment who need it most. So you could say in a quest towards precision medicine.
Which really demonstrated something I think that ends up being important for all of us to start thinking about is it could potentially be a mechanism to demonstrate that you had an effective therapy. Yes. It allows you to adjudicate who is going to benefit from the therapy, and B, then demonstrated that the therapy was beneficial, that it decreased the inflammation. Yeah. You have to still do an outcome study that also shows that, but that it showed that there was longitudinal benefit, and you can say that essentially that the drug was working.
Yes.
There's a very interesting sub-study of the REPRIEVE trial that is ongoing right now. So REPRIEVE, as you know, was pitavastatin in patients with HIV who are at increased cardiovascular risk. And it demonstrated a 20% decreased risk in cardiovascular events. And there's a sub-study of about 10% of patients who got CT scans at the beginning of the trial and at 1 year, I believe. And they're now looking at the CTAs. The CTAs themselves demonstrated a decreased vulnerable plaque burden. And now they're looking at inflammation as a sub-study of that. Because one of the things that we're lacking in cardiovascular disease in general is the ability to tell our patients that we're successful. Right now, we're successful when they live to be 90. And it would be nice to say that, yes, your therapy is doing what we would expect it to.
Yes.
I guess one of the questions you have on the orticumab is, what do you believe the mechanism was of decreasing the inflammation?
This isn't something that this small clinical pilot trial is going to tell us anything about. This would be the preclinical work that has given us some of these insights. But at the end of the day, I always say, you can use fire without having to understand fire. Whatever the mechanisms are, it seems to be a very effective drug. And I think there's enough evidence now to justify a much larger trial. And that's what's currently being planned by the company.
There are a number of trials, I understand, that are going to be using FAI. I believe that the Zeus trial has published that they're going to be doing a subset of their patients looking at an anti-IL-6 drug. And that will be very interesting. I think that there'll be other trials for other anti-inflammatory agents. And like I said, my sense is that any cardiovascular outcome trial ought to start looking at this as a mechanism to see, what risk are their patients really at? You have a much more granular ability to identify someone's risk than just our basic pooled cohort equation. So you should be able to get a much greater sense of the patients coming into a trial based upon using FAI score. And then if you could do a secondary look, you should be able to see some type of decreasing of the inflammation, since in general, atherosclerosis goes through a mechanism of inflammation before you have an event.
I couldn't have said it better.
One of the other questions that we had on FAI was other utilities for FAI. And one of the ones that I'm very excited about that you had mentioned in one of your other papers was the use of FAI in MINOCA. Can you just walk us through that a bit?
Yeah, so I can talk about how much we know about this. So first of all, Clearly, Minoka remains a diagnostic challenge, as we want to make sure we give the patient the right diagnosis and therefore the right treatment advice. And the first thing to say is that in my practice as a CMR doctor, Minoka is a frequent reason for referral for cardiac MR. And with this method, we can often, although not always, clarify the underlying pathology. So, for example, we may find a pattern typical of acute myocarditis, or you might see a small embolic infarct that could not be picked up by the angiogram. So CMR is now an established standard imaging technique in Minoka. With regard to FAI, I'm only aware of one full published paper by Guy Bazzi and colleagues from Italy, which was published in JAHA in 2019, I believe. And that's looked at this systematically. And in patients with Minoka, they indeed found coronary inflammation assessed by FAI in all three coronary arteries. There are also a couple of small early studies on pericoronary fat attenuation in SCAT, in coronary artery dissection. And there's one larger ongoing collaboration we have with the University of Leicester that is still being completed. And there's also some speculation that inflamed pericoronary fat may contribute to coronary vasospasm and potentially cause some cases of Minoka that way. So all this is very promising, I think, but it's still early days, and we need more studies to precisely define the potential role of FAI in this diagnosis of Minoka and SCAT patients as well. So I'd still say watch this space for the time being.
There's clearly going to end up being a space in which we start talking about lipids as one part of the diagnosis. We start talking about inflammation as a second part of a diagnosis, and probably thrombosis as a third piece. And these three pieces really do interact. Yeah. And so certainly for Minoka, that's has to be part of the events. There's other diseases that are going to be similar, I think, in our way of looking at them. Rheumatologic diseases clearly is going to be one. You had mentioned that you're going to be doing some sub-studies in ORFAN to look at those patients.
Yes.
Currently, there's no really good way of identifying who's going to be at higher risk, but we know that they are at higher risk. And there's going to be other patients like diabetics that we have identification of increased inflammatory risk, but we haven't clearly identified their cardiac inflammatory risk.
Agreed.
So one of the trials that was also presented at the ACC this year was a sub-study of LDOCA-2, which did not demonstrate an improvement in coronary inflammation as identified on the AutoPlaque software. Can you discuss that? Because it does seem like that should have been a trial that would have been positive.
Yes. So we're very aware that this work in this sub-study of LDOCA-2 suggested no improvement in PVAT inflammation. Now, we were not involved in this study, but I think there are likely several potential reasons for the negative result. So firstly, the study design was such that there was no baseline CT scan. It was only a scan after treatment. So the investigators relied on detecting group differences at that point, rather than being able to make a paired comparison of changes in PVAT due to colchicine treatment. Secondly, it's likely that anti-inflammatory treatment is indicated for some patients, but not for all. And, we've clearly shown in the Abcentra trial that pre-selecting patients for high baseline inflammation can demonstrate the effect of an anti-inflammatory agent on PVAT, while in that trial, changes for the unselected patient group were also not significant. So it's really not surprising. The LDOCA-2 sub-study could not pre-select patients for high levels of inflammation, as there was no baseline CT scan. And then finally, there are likely technical reasons as well. We know that simply measuring PVAT attenuation, as it was done in this study, gives you some kind of signal on PVAT, but it's just not very precise. And this is because we've learned with Caristo that there are many confounders that need to be taken into account to standardize the FAI signal. This includes anatomical, biological, technical, and patient-specific factors. And this is exactly why Caristo has developed the FAI score as a robust, standardized measure. And so are we surprised that this study was negative? Probably not really. Are there good reasons for why that is? I think yes. And so finally, I do want to mention in this context that we're currently performing what's called the VERDICT study, VIRDICT. And this is led by Alex Antonopoulos and colleagues. And here we are looking at the effects of colchicine with repeated CT scans and with FAI Score as the primary endpoint. So more information will soon be available on this question.
At what period of time are you going to be studying with that?
So this study I've just described has a 6-month follow-up.
That would be interesting if you're able to see that kind of difference so quickly, even with colchicine, which is a bit of a non-specific anti-inflammatory agent versus some of the more specific ones. So I'm very hopeful that you'll see that. So Dr. Neubauer, you've developed a CT imaging program at Oxford. Can you just walk us through a little bit about what it's like and how that was developed?
Maybe go even one step further back. When I came here in 2000, I've started what we call OCMR, the Oxford Centre for Clinical Magnetic Resonance Research, and I've been running this for the last 24 years. It's a combined clinical and clinical research center with about 60 people working in that group, and we've got 1.5, 3, and 7 Tesla MR systems, and that's been going very well over the last almost quarter century. But we now have a sister unit to this OCMR center. And 2 years ago, we started what we call the Acute Multidisciplinary Imaging and Interventional Center, also called AMIC. And this is led by Haris Antoniades, who I've introduced before as the deputy head of our division of cardiovascular medicine, and really the inventor of the fat attenuation technology as well. And AMIC combines a state-of-the-art cath lab with the latest generation CT scanner. And this is a photon counting CT from Siemens. It's called a Neotom Alpha. And then the AMIC Center, in addition, has also established a deep learning server infrastructure. And this is what's needed for our big data work with ORFAN to eventually store all these 250,000 cardiac CT scans. So that's the setup we have in Oxford. And I think we're very fortunate to have this.
You are also the co-founder of Caristo Diagnostics, along with Dr. Antonides. Can you just walk us through Caristo Diagnostic and who you are and what you've been able to develop?
So Caristo is a university spin-out company. As you say, I founded together with 3 of my university colleagues in 2018 with Haris Antoniades, but also Keith Shannon and Chirag Shirodaria, with the goal to bring the FAI technology to clinical practice. So we currently employ 41 people. And I would say we've already made major progress in this direction. This clinical tool that we're developing is called CariHeart. And what we realized early on is that for reliable clinical assessment, you cannot just make these FAI measurements and take the numbers as they come out from the images. So instead, for this to be a reliable and reproducible measure of cardiovascular risk, the measurements need to be highly standardized for anatomical, biological, technical, and patient-specific factors. And so this includes things like which coronary arteries analyzed and where in the coronary artery tree you take the measurement, scanner type, acquisition protocol, tube voltage, patient body size, gender, the list goes on. So once you take all this into account, the result will be independent of all these factors and only reflects the level of tissue inflammation. And there's just no other technology that does that. So we use artificial intelligence and machine learning algorithms to calculate a standardized FAI index, and we then call this not FAI, but FAI Score. And the FAI Score tells us what the patient's relative risk is compared to an age and gender matched group of people. In other words, which percentile of risk the patient falls on. And that information obviously is age independent. As a second piece of AI-generated information, we then also take into account coronary plaques and stenosis, as well as a series of other patient characteristics like their traditional risk factors. The AI algorithm then calculates the absolute risk of dying from a heart attack in the next 8 years. And this is the AI-generated so-called CariHeart risk. And then on top of all that, CariHeart also provides quantitative plaque measurements, such as for total calcified, non-calcified, and low attenuation plaque. And this is the technology Caristo has developed. It's now regulatory cleared in the UK, Europe, and Australia. And we aim to achieve FDA clearance in the next 6 to 12 months, so that then hopefully this technique can also be used in the US for patient care.
Also understand that you hold the patent for this technology. So this is going to end up being the standard of care when we're looking at coronary inflammation.
Absolutely. There are multiple patents that secure and describe this technology.
We previously had a discussion with Dr. Shirodaria, and obviously it's an extremely, extremely interesting bit of kit for looking at coronary inflammation. And I truly believe that looking at inflammation is going to be as important, if not maybe more so, than what we've been doing over the years at looking at angiograms. And then secondarily, looking at inflammation is going to be probably just as important as lipidology has been over the past 50 years, leading to new therapies and new ways of looking at coronary artery disease.
Yeah, completely. Okay.
So one other question that I have, or two other questions, if you don't mind. One is, where do you think that CT research is going to go in the future? The resolution of CT scans are getting better. We're going to be able to do more AI assessment of plaque. But what do you think is going to be exciting in this space?
Yeah, so I think, generally for CT and CMR, where is it all going, the cross-sectional imaging? I mean, it is quite a general question. It's a huge field with many, many new developments. And I could probably only do real proper justice to answering this question with something like a 30-page review article. But, let me make a few general and specific remarks here that I think apply to both CT and CMR, which are, still working very heavily. So the first is medical imaging accompanies us throughout our lives. And this now ranges all the way from prenatal ultrasound to CT-based autopsy and everything in between. And imaging biomarkers continue to become ever more important as they can go a long way to enable us to achieve precision medicine, where diagnosis and treatment decisions are tailored to the individual patient rather than to a disease label. And the developments we are seeing in both CT and MR imaging and other forms of imaging, I think are breathtaking in this regard. And many of them, of course, are led by applications of machine learning and AI. Our work on coronary FAI is one example. There are various other AI-based image markers we are working on, for example, for application atrial fibrillation or to diagnose the existence of diabetes or prediabetes from fat textures in CT scans. It's a little too early to talk about these in detail, but those I think are promising developments.
I think that it will be very interesting to see in the off-target organs and off-target fatty tissues what we're going to be able to see as far as inflammations, perinephric fat, pericardial fat, visceral fat, and how those things are going to end up interacting. Because clearly it's harder to do a CTA. And if you could go back and retrospectively analyze every CT of anyone's abdomen and identify those who have increased inflammation, that will clearly be another step forward.
Yeah, that's totally in line with our thinking.
Outside of the imaging space, whose research are you interested in? Are there other things where you pick something up and say, wow, that's really cool. I'm really excited about where they're going.
Yeah, again, those are interesting questions that you can spend a long time. But I have to say, that the number one thing that excites me would be my colleague Hugh Watkins' work in Oxford here that is funded by the British Heart Foundation Big Beat Challenge with £30 million, the Cure Heart program, where he is working together with a number of top genetic groups in the world, such as the Seidmans in Boston and Eric Olson in Texas, etc., to find cures, genetic cures for cardiomyopathies, in particular hypertrophic cardiomyopathy. Currently, apart from maybe the new myosin inhibitors, don't really have ways to causally treat these diseases. We can symptomatically treat them, or we can give these patients an ICD to make sure that they don't suffer from sudden cardiac death. But to actually be able to cure these diseases by modifying the gene expression of the 40 genes and putting that right would be incredibly exciting. At least 1 in 500 people is affected by hypertrophic cardiomyopathy. And I think if that can happen, and I know that team is working very hard on that, I think that would be incredibly exciting. I think if I can witness that in my life and professional life, I think I would be very, very pleased, also for the many patients that would affect so positively.
Well, certainly your work that you've done in CMR and describing the cardiac morphology in these diseases has been groundbreaking for that, and certainly gave a lot of the basis for what they're doing, gave them a foothold so that they can understand what was happening.
Thank you. But so once I think that the Watkins group, once they are ready to start their initial clinical trials, we are ready with the phenotyping tools to actually look at efficacy of whatever that new treatment will be. So we can not only look at regression of hypertrophy, but regression of fibrosis, regional function. We can look at oxygenation and stress oxygenation, regional perfusion levels, regional metabolism, to really look whether these drugs change the parameters that they are meant to change in the first place.
It's going to be really incredible work. Thank you again, and I do appreciate you taking your time today. These are great papers. I hope everyone gets a chance to read them, and I hope that you and I get a chance to talk again.
Yes, very welcome, and I very much enjoyed this. Thanks very much.
Thank you.